know the clotting factors in each system. You got to know the common factors. You got to know how to diagram them. So the first thing you will do on your test next week is you will diagram them on a blank sheet of paper. You will put the intrinsic and extrinsic, and you'll see how they join to make the common factors. So we will draw them on the board, you will draw them on your paper, and then I already have the key copy of how I draw. Okay, that way you have a couple choices. And as long as it's done accurately, it doesn't have to be done my chart, but it has to be accurate. Okay? So we're going to go through there's a few ways to classify them, and we won't use adsorbed plasma or age serum until we get to a test method called a substitution study. I make you do it on paper, but this is a way that I know you know your clotting factors. When you can do a substitution or mixing study and you know how to use two reagents called adsorbed plasma and age serum, then I know you understand your clotting factors. And you know you'll do fine on your registry in that area. So, those are the names again that we already know that one will be on test 1. Because test 2 has a lot of information already. I needed to put some of that on test 1 to balance it a little bit. There's other ways we already know we're going to learn. We're going to learn extrinsic, and we're going to learn intrinsic, and we're going to learn common factors. That is the classic way you identify your clotting factors. But you also have to know how else they can be classified. You can break them into what is called the contact group. You can break them into what is called the fibrinogen group. And then you can break them into what is called the prothrombin group. The prothrombin group will be a big one we focus on because coumadin affects everything that's in the prothrombin group. And that will help you understand how coumadin works. So the contact group, think of anything that begins the intrinsic system. We know collagen being exposed when the vessel endothelial tissue is damaged is what triggers it. But, so if we have collagen, then the factors that are considered contact are prekallikrein, 11, 12, 11 prekallikrein, and high molecular weight kininogen. We won't talk about the Fitzgerald and Fletcher factor till tomorrow, but they are part of the minor system, and their job is one thing in low concentrations, and it's another thing in high concentrations. So the tricky part, remember, is knowing what happens when you don't have a lot of it. It's a low concentrated substance. And what happens when too much gets out in circulation. So the contact group, you could group these as 1211, Fletcher, and Fitzgerald. There's another group called the fibrinogen group. Well, at least you know if it's called the fibrinogen group, fibrinogen is going to be there. And one of the things that will help, we're going to list what's in adsorbed plasma and what's in age serum. So that's adsorbed. These will be reagents we use in a substitution and these are fun when you get the hang of them. And one's called aged serum. You can take citrated plasma and you can add aluminum hydroxide and let it sit, then centrifuge it, and you'll have certain factors remaining out of all of the factors in that plasma. Serum, you can let a clot sit, like a red top tube, sit at 37 for 4 hours, and then centrifuge it and remove it, and it's going to have certain clotting factors remaining. So what they're saying is 11 and 12 are in both plasma and serum. They'll be remaining in both. The fibrinogen group, you know, one is going to be in it if it's called the fibrinogen group. The two labile factors are also part of that group. They don't last very long. They're the two big reasons you got to run your coag in a couple hours. Don't let it sit on the cells, take it off the cells, centrifuge it, run it within 2 hours of collection. Those are labile factors. If they deplete and are ineffective, that's going to make the physician think they have a problem, that their ProTime and PTT take too long to clot. So think, when it's deficient, you're taking too long to clot. So instead of 10 to 13 seconds on a ProTime, you're going to be longer. Instead of 28 to 36 seconds for a PTT, you're going to be longer. When you're missing clotting factors, it takes longer to form that fibrin clot. So 1, 5, 8, and we'll see that 13 does not form the clot. When we diagram it, you'll see that 13 comes in after the fact and stabilizes it. If you don't have enough 13, what's going to happen? Let's say you have surgery. You're initially, the first day after surgery, good. Then all of a sudden, 36 hours later, you start oozing at the suture site. You don't have enough 13. 13 isn't making the clot stay longer, as long as the vessel needs to heal. So adsorbed plasma has 1, 5, and 8. They're not in serum. So if I add aluminum hydroxide to citrated plasma that I removed from a blue top, let it incubate, then centrifuge it, those would be the factors remaining. 1, 5, 8, 11, and 12. This will make more sense. Like I told you, we'll review again. What you already know a lot of information with a ProTime and a PTT. You can get it down to 4 factors at the most, just by knowing what's in ProTime and PTT. Now, with these reagents, I'll be able to help you get it down to 1. So we'll learn how to use them in like an investigation, how they work once you get it down to 4 factors. So that is another way you can classify. So you have the contact group, you have the fibrinogen group, the last group, and this is going to be the key one I test you on, is the prothrombin group. The big reason is this: it is vitamin K dependent. How do you think coumadin works? Coumadin acts on vitamin K. So if you need vitamin K to make all of these, you put them on coumadin, it wipes out the vitamin K source. So you'll see 7 is the first factor that needs to be remade. And there's no vitamin K, they can't be remade. That's why your ProTime is the first thing to go up. Ultimately, when we talk about coumadin and heparin, you're going to see how both ProTime and PTT are elevated, whether you're on coumadin or whether you're on heparin. But the first factor that's depleted when they put you on coumadin is 7. It has what is called the shortest half-life. It needs to be remade more quickly than the others. So naturally, that's your main factor in your extrinsic system. That ProTime is going to be elevated before the PTT will show it. But ultimately, someone's on Coumadin a long time, 9 and 10 and 2 are all in the intrinsic as well. So you can see they're going to affect the PTT. Heparin, we monitor it primarily with the PTT. They are moving towards an anti-factor 10 because a lot of hospitals are using low molecular weight heparin, which we'll talk about when we get to the anticoagulant therapy. And ultimately, both ProTime and PTT will be elevated when you're on heparin. But initially, the PTT is the first thing to go up. So it's not that both aren't elevated when you're on Coumadin and heparin. The first one to elevate on Coumadin is the ProTime. The first one to elevate on heparin is the PTT. But ultimately, they both are. Okay, so you gotta know 2, 7, 9, and 10 are vitamin K dependent factors. That's the one group I want you to know for test 2. So on your PowerPoint, put test 2 by the prothrombin group, because that's going to come up regularly, especially when we talk about Coumadin. Protein CNS, those are natural inhibitors that we'll talk about tomorrow with the minor system. Protein C is the one I told you my daughter's girlfriend got her first DVT on a long flight overseas with her job. Then she's had her second one, and now she just had a baby, had to be on heparin her whole time, had the PE, the pulmonary embolism, and they're only 32. And none of her family has a protein C deficiency, but she has one. It is a natural inhibitor of factors 5 and 8. You can't let these factors go on and on and on. You're going to form blood clots when you don't need them. So you have to have natural inhibitors in place. And protein CNS, we'll learn tomorrow, are 2 of them. And they keep your factors 5 and 8 in check. So that'll be the one of the 3 groups you have to know for me for the test. It's the prothrombin group. That one's going to come up a lot. So ultimately, the other factors in H serum are 7, 9, 10, 11, 12. And remember, I'm a big fan of learning them in order. When we do the diagramming, we'll learn them in order of how they affect each other and absorb plasma. So by the time, yes?
I'm sorry, you said protein CNS are natural inhibitors to 5 and 8?
Factors 5 and 8.
Okay.
Yep. And we'll discuss them tomorrow. They're one of the minor systems. They're called protease inhibitors, and protein CNS comes up. When we get to the test where we do substitution studies, I have you write a lot of information on the front of your test, but it helps. You write your extrinsic factors in order, intrinsic factors in order. Normal plasma has all factors. Adsorbed plasma, 1, 5, 8, 11, and 12. AS, 7, 9, 10, 11, and 12. Because you got them written down before you look at a question. And it helps. So down the road, you'll write like 5 different things on the front of your test to refer to before you look at a test question. Because instead of mixing them up because you think, oh, wait a minute, no, that's the intrinsic. Oh, no, that's the extrinsic. Oh, no, that was an H serum. Oh, no, that was absorbed plasma. You've got it written down before you ever get yourself questioning from memory. And it really helps. So those will be 2 of the things you write down as well. So these 2 things won't make much sense right now, but you're going to see how we use them. It's kind of figure out our puzzle, what factor is deficient. It's a whole exercise if you in your syllabus on substitution studies, and there's 4 scenarios, and sometimes there's 3 pieces to each scenario. But you understand that, you understand your clotting factors. So that's always my goal. Everybody gets the substitution studies because that's a big piece that you understand it for the registry. Now, this is a hard piece, and I like to, one of the things I copied is a really good table that shows the steps of thrombin and the steps of plasmin. So it's kind of a two-sided document that I took from an older textbook that coag is hard because there's so many checks and balances. And they do one job in low concentrations, they do another job in high concentrations. So it's a tough concept for a lot of people to understand. It doesn't just have one job and you know it, and that's all you gotta know. So thrombin, and this will make more sense when we diagram it. But thrombin in your clotting system, you're going to have to know what is your main enzyme in the next three systems. So you're going to have to know what is the main enzyme for your clotting system. You're going to have to know what is the main enzyme for your fibrinolytic or breaking down of the clot. And then you're going to have to know what is the main enzyme of one of our minor systems called the kinin. The clotting system, the main enzyme is thrombin. And when we diagram it, you will see that it's 2A. But normally it's called thrombin. Normally fibrinogen is called fibrinogen, prothrombin is called prothrombin. Certain factors, they're known by their numbers. Right? 5 through 12 are known more commonly by their number. But the main enzyme for the clotting system is thrombin, and that's 2A. So what are its jobs? This is its main job. And if it helps you to put low concentrations above small amounts, high concentrations, it's one and the same. In low concentrations are small amounts. Its main job is to take factor 1 and make a fibrin clot. That is ultimately its main job. But when it gets to 2 excess in your serum at high concentrations, it has a shutoff valve and it says, uh-oh, I've already done too much. I've got to trigger the fibrinolytic system to get here to break it down once it's done its job, form its clot, got smooth, continuous blood flow back. Because I don't want that clot to keep growing and becoming a thrombus. So in high concentrations or large amounts, it's going to trigger fibrinolysis. Plasminogen to plasmin is fibrinolysis, our fourth system. One of the things that also can help, if you have any thrombin formation, because remember the vessel releases factor 3. Factor 3 is the extrinsic clotting system. It can start forming thrombin to make that fibrin clot. It can help activate more platelets, that thrombin. And you'll see when we diagram it, factor 5, factor 8, and factor 13 need to be further activated by the presence of thrombin. It makes them complete their job. So when we diagram it, and you for the test, you're going to have to show me, once you get to factor 2A, how it goes back up to 5, goes back up to 8, and it triggers 13 to become activated and stabilize the clot. So when we diagram it, you'll see how it does this job. And that'll be points off if you don't show me on your diagram where it does make 5, 8, and 13 do their job completely. Okay, now look at your the left side of the diagram. So when thrombin acts on fibrinogen, it just doesn't go, boom, it's the fibrin clot. There's steps. And back in the day, when I first started in lab, we didn't have a test for fibrinopeptides A and B, but we had a test called FS, soluble fibrin monomers, that we did for a disease called DIC. Now we do the D-dimer test that we're going to do on Thursday. And then when it's completed, the fibrin clot, it polymerizes or joins or cross-links. So this is just to show you, you don't have to know it for anything other than when thrombin acts on fibrinogen, the first thing it does is forms fibrinopeptides A and B. Then they become fibrin monomers, and they polymerize and become, and if you want to put the stable fibrin clot, fibrin polymers. So what I'm trying to show you is, it doesn't just go factor one in the fibrin clot. There's multiple steps. Just like when we talk about fibrinolysis, this you're going to see are multiple byproducts when you break down a clot. Okay, so on the left-hand side, if you want to put clotting, this is going to be fibrinolysis, the right-hand side. So this one diagram shows clotting on the left-hand side and how you start breaking down the clot on the right-hand side. And remember, I'm a fan of you understanding what you're doing. I think it's pointless to memorize for just the sake. Sure, you got to memorize certain things just to build your base. But then, if you understand what you're doing, you're a much better tech. You'll question things. Like, for instance, one time, we had a physician. And you try to be polite. I mean, if they only use the lab people like they should. The person had an abnormal protimin PTT. So they wanted to do a factor 7, a factor 10, and like a factor 2. And we tried to call and say, you don't need to do a factor 7. Why? Why do they not need to do a factor 7? The PTT was elevated. The protein was elevated. It had to be a common factor, right? 10, 5, 2, or 1. But, oh my goodness. They did not want us telling them what to do. So they wasted a lot of money for the patient running a factor 7 when we already knew it was a common factor. What would have been the difference if the 7 would have been valid? What would have been the difference of the protein of PTT? Which one would have been normal?
Protein.
The PTT, there's no 7 in PTT, so if they're worried about 7 being deficient, the protein should have been. So you know a lot when you understand your clotting factors. That ideally how we should be used in the lab, especially if they want to make different levels. They want to do MLT 2-year, MLT 4-year, Master's MT, 4-year MT, and then a PhD, then they should use them to help the physicians order accurately what is necessary so they don't waste all this money that the patient gets charged for. And so don't minimize what you know. You're going to do better for the patient by knowing what you're doing with each test and just, oh no, I think that's right. That's all I know is it was elevated, so it has to be the right answer. I don't know what it means. I don't know what factor it means or whatever. So remember, you want to be the most knowledgeable tech. Your goal should be you want people to come to you because you understand what you're doing. You don't just know how to run a machine. You understand how it works. So remember, fibrin just doesn't go from the fibrinogen to the fibrin clot. Fibrinopeptides A and B, fibrin monomer, fibrin polymer, the stabilized fibrin, and the dimer, then polymer, which is the stabilized fibrin clot. I got pathways on there, but I'm going to show you how I diagram it. I think I'll diagram it on the Elmo. I think it'll be clearer. And then I'll give you my key, and then you'll have a key, and then remember, we're going to try to, I already lose my pen. Okay, tell me what you do know. Let's put on the board what you do know, and we're gonna diagram I think the paper, you'll see it a little clearer than the fuzzy board. Tell me what you know is in the protime in the extrinsic system. Factors in order.
3, 7, 10, 5, 3, 1.
Okay? And what do you know? And then we're gonna go, this is gonna be the seconds we use for normal for our test. Remember, the normal ranges can vary lab to lab, area to area. We'll use this for our lab. What are the factors in the intrinsic in order?
11, 9, 8, 10, 5, 2, 1.
And you need to do them in Roman numerals today. Okay? Normally, the drug we monitor is Coumadin. And the drug we monitor with the PTT is heparin. Normally, we like the INR to be between 2 and 3 if they're on good anticoagulation. They don't have like recurring heart attacks. And in the heparin, normally we like it 60 to 80 seconds, the PTT. If the physician knows you're on heparin and you're in between 60 and 80 seconds, they know it's a good range. But we'll see what's the problem with that as we get into Coumadin and heparin in another lecture. For just now, this is information that is kind of basic information. So let's diagram, and how I like to diagram is I like to start with the extrinsic, bring it to 10. Then I start with the intrinsic, bring it to 10. Then we only have to write the common steps once. So that's how you want to do it on your real test. Okay? So I usually put the protime on the left, PTT on the right. How do you get 3? Oops, sorry. How do you get factor 3 for tomorrow's test?
You add everybody's efficiency.
When you have vessel damage, factor 3 is one of the things released. Okay?
You have it zoomed in, that might have been it.
Oh, maybe I just have it too. I probably have it too. Sorry. Okay. Then you tell me what happens. And I'll write it how you have to write it. One of the things you got to be aware of in coag is once a factor, it's like a domino effect. Once a factor gets activated, it becomes an activated factor. So I like to write with a little a once it's activated. The only 2 I don't like to write with an A is factors 5 and factors 8. They are the 2 major cofactors. Like their role is more important than the other factors besides 1. Naturally, that becomes the fiber and clot. So the 2 cofactors I don't write as 5A or 8A. You're going to see a little bit different takes. One of the things the book also does is have 7 comes over and activates 9. I keep them totally separate. You're beginning learning. If you learn it my way, you can build to more in depth. So 7 becomes activated 7A. And guess what? In the presence of factor 4, calcium. They don't write factor 4. They write it as calcium. So we don't write it with 4 in either system. It's just required throughout. And then how does our sodium citrate tubes work? Binds calcium. So what do both test methods have to add back? Calcium. Thromboplastin C, if you ever take the time to look at the bottle, that's what the C is, calcium. And then what's the second reagent in the PTT? Calcium. Yeah, PTT reagent and then calcium. Okay? So we're going to come over and 10A. Okay? So that's all so far. You have to write for the extrinsic. Because 3 is released from the damaged vessel. What gets released from the damaged vessel that triggers factor 12 on the PTT side? Anybody remember? It's called collagen. So it acts on 12 to become 12A. Then what's 12A act on? What are your factors? So if you write your factors up, you know what it acts on next, right? So 12A acts on what factor? 11. And then what's 11 work on? Sorry, I didn't mean to box that. It didn't need to be boxed. What's 11 work on? I should have had this a little lower. Now, 9A joins the cofactor 8, and it also joins calcium. And what is released during the release reaction that allows for the fibrin clot to join the platelet plug?
PF3.
PF3. So there are two places. This is when I needed to box. 9A plus cofactor 8 plus calcium plus PF3.
What's that one in the box again?
9A,
No, the one you said is not a box one.
that's not supposed to be a box. That's just 11A. I just wanted to put it over the XI and the bottom of XI, and I made a box, and I shouldn't have. This, when the cofactors, if you keep in mind 5 and 8 are the cofactors, every time there's a cofactor, there's one other activated factor, and there's calcium and PF3. So there's one other place we're going to do a box like this. So then this comes over to act on 10. And one place there's calcium is here. 9 to 9A needs calcium. 7 to 7A needs calcium. When you use both cofactors, 5 and 8, you need calcium and PF3. That's where it's going to hook up. Yes.
What is PG?
Sorry, my good right. I have a diagram I'll give you guys. That's 9A, 8, calcium, and PF3. Now they've gotten to the common factors. Yes.
Sorry, calcium is present when
7 to 7A and 9 to 9A. And with the cofactors 5 and 8. So we have another place we're going to add it. And then I'll give you a handout because I have a diagram made. So now we're to the common factors, 10, 5, 2, and 1. So that's why you want to draw them on one sheet and get to the common factors. 10A, what's the other cofactor we still need to use? We've used 8. What are the two things we need anytime you use a cofactor?
Calcium.
And then what's our last? So we have 10, 5, 2, and then what's our last factor? That's the common factor.
1.
I wrote prothrombin, I wrote thrombin, and I wrote fibrinogen. You're going to hear those factors more by their name than by their number. And maybe factor 1 you will hear more than factor 2 or thrombin 2A. But now go back to the jobs of thrombin. The last job, what 3 things did it make better? Once you had thrombin farm, what did it enhance the activity of? If you keep in mind, it enhanced the activity of both cofactors
5, 8, and 13.
and 13. And I'll show you what 13 does. So this is what you got to do on your diagram for your test next week. You got to take thrombin, and does anybody remember 13's name? Fibrin stabilizing factor. So once you have 13, it stabilizes the fibrin clot. So it's a two-sided. The back side we won't probably get to till tomorrow, but you'll still have it. And I don't care, you use my diagram, your diagram, as long as it's correct. I don't care what you use. See if that's enough. I don't know if I shortchanged you. See if there's enough. There is 2 left. The back side is for the fibrinolysis. So, remember, let's recap. 3 gets released from the damaged vessel. It activates 7 to 7A in the presence of calcium. It goes to act on the common factor 10. Collagen gets exposed from the damaged vessel. It activates 12 to 12A. 12A activates 11 to 11A. 11A activates 9 to 9A in the presence of calcium. 9A works with the first cofactor, 8, calcium, and PF3 to act on 10. Now we're in the common factors. The first step is 10A, acts with your second cofactor, 5, and calcium and PF3. That breaks prothrombin into thrombin, the main enzyme of forming a clot. And then fibrinogen becomes the fibrin clot. And we already showed you the diagram. It does fibrinopeptides A and B. It does fibrin monomer. It does fibrin dimers. And then it polymerizes to cause the final fibrin clot. And then thrombin's job in low concentrations forms the clot. In high concentrations, it's going to trigger the system we'll talk about tomorrow to break it down once it's done its job. Plasminogen to plasmin. It can activate more platelets as it's being formed, and it enhances the activity of 5-8 and is what activates 13 to become activated 13 and stabilize the fibrin clot. So tell me what you know now and see if you understand this better today. Because on test 2, you've got to understand that at least down to 4 factors. What does that get you down to?
7.
And why not 3?
Because it's the reagent.
It's the reagent. What does that get you down to?
12, 11, 9, and 8.
Because it has to be something that's only in the PTT, right? Because the pro time was normal, so that eliminated a common factor. So 12, 11, 9, or 8. The third scenario. Now what's that get you down to?
The common factor.
Has to be something in both systems. And the last scenario is this. Proton and PTT are normal, but the person starts oozing from their suture site like a day and a half to 2 days later. 13. You gotta know this for your registry. Factor 13 deficiency does nothing to the proton and PTT. You can make that clot in a test system really quickly. It's on the patient side. What happens to the patient side is they start oozing at their suture site. Everything was fine, they're healing properly, and all of a sudden they start bleeding from their suture site. And there's a test I'll teach you called the 5 molar urea. We don't have it, but it's something we'll talk about, of how you see if the clot dissolves in 24 hours. You'll know it's factor 13. But this is a big deal, because I've seen that on registry. They expect you to know factor 13 has a normal proton and PTT. It affects it at the patient in after the fact. Your in vitro testing would be normal on the proton PTT. So are you okay? Are you better today with these? So if you want to stay after, and anybody else wants to stay after, okay? Because, so on your PowerPoint, there's a couple diagrams. There's a diagram. There's a diagram. There's a diagram. If you look at any textbook, you're going to have diagrams. But what I gave you is what you have to know for my test for me. You got to have your calcium. I mean, if you miss a calcium, it might be 0.5 off. You know, it's going to be a bigger deal if you miss them in the right order of your factors. But what I gave you is what you got to know for me for the test. But there's multiple types of diagrams out there. And then this is showing how the clot forms in the different steps. Okay, so we're going to leave the next 2 PowerPoints for tomorrow after lecture, because fibrinolysis is kind of tricky. A lot of people struggle with that, and you already got one diagram thrown at you. You'll have to have another one tomorrow. So you have it on the back side. And what will be good about doing it tomorrow, you'll understand the D-dimer test that we're gonna do on Thursday. Because it's a disease state called DXC, or if you have excess clot formation, that the D-dimer comes into play. And I've stopped teaching this year the FDP because every lab's given it up. I don't know if I know one lab doing the FDP test anymore. And in all fairness, it was positive whether you had a disease state called primary fibrinolysis or it was positive if you had DXC. So it really didn't distinguish them. So it didn't really help you in the big scheme of things. Okay. So anybody who wants help on understanding what your factor is remaining, you know a lot from that pro time and PTT. Okay? Okay, so we're gonna move the desk, we're gonna get in a circle, and we're gonna review. So you guys gotta move your desk somehow, and you guys move yours. And then we wanna do a circle, everybody sitting, and I'll do like my last class, like I told you. The student who hardly ever missed a question on the test didn't want to answer a question. And two of my ones that struggled a little always wanted to answer. So it benefited probably more my weaker test takers. Not that they weren't knowledgeable, they just struggled on the written test. And so we're going to try it because